Það efni frá skurðdeildinni, það er Alise sem ætlar að tala komplikasjónum við gallblöðru. Aðalega hvað á injuries eða hvað er þetta? Læknir, bile duct syndrome.
Yes, okay. So my name is Alise Bruvere. Most of the people knows me. Good morning, dear colleagues. I will talk today about a surgical topic, but I hope then this topic and this knowledge what you can get today, you also other doctors and other specialties can use, at least to know what is this pathology, and if sometimes you are seeing in medical history of the patients then this fact were like bile duct injury during operation, so you will be informed more what is it. So the topic is iatrogenic bile duct injuries during laparoscopic cholecystectomy. Laparoscopic cholecystectomy. This is a treatment for gallstone disease. To understand this topic, I will talk a lot about anatomy today and bile ducts. I want to remind then in biliary tree, bile ducts are left hepatic, right hepatic, common hepatic duct, cystic duct, and then common bile duct, which is going into bowel, small intestine. Laparoscopic cholecystectomy, it's a gold standard for gallstone disease, and the aim of operation is to remove gallbladder, to dissect and to clip a cystic duct, not a common bile duct, and a cystic artery, and to do it as much as gentle as possible, and of course to avoid all other structure damages. This topic is quite actual. You can see in this scheme that gallbladder operation in this hospital during these years are still high in numbers. The red is laparoscopic operations, and the green is open operations. So, and this is very like in other hospitals as well. So it's in every hospital who is doing these operations, it's quite high numbers. Well, there is a different complications during, could be different complications during laparoscopic cholecystectomy. Usually we're dividing them in two big groups. One complication could occur during the operation, and they could be visible during the operation, and another is postoperative complication. Intraoperative complication can be bleeding, bowel injury when inserting trocars, or dissecting, for example, adhesions, liver injury, bile duct injury, partial transection or ligation of the bile ducts, and bile leaks. And postoperative, hematomas as well, bile leakage, bile peritonitis, jaundice, peritonitis due bowel injury, and of course later wound infection also can be possible. Bile duct injuries, it's a major complication, and this is very not a happy thing when it happens. The incidence of during laparoscopy bile duct injury is worldwide known, then it is from 0.2 till 0.7%. Versus open laparoscopy, versus open operation for gallbladder, it's of course it's a little bit less. No, it's much less actually. 0.1 till 0.04%. So why it's happened? And there is different risk factors, and I will try to go through them. First is anatomical variations. And there is a very different anatomical variation than could be, and they usually not very known before elective surgery. Here on the right picture, we can see that how different can look in reality cystic duct and common bile duct. But on the left side, we can see how different can be liver ducts, and there is a possibility then also additional right hepatic duct can be, and how they are, that's forming this biliary tree. Next risk factor. So of course it's good to know about this anatomical things, but it's not usually known, especially if there is a routine diagnostic before elective surgery. It's usually only ultrasound, and it's impossible to know this small things. Next aspect is acute or elective laparoscopic cholecystectomy. So I would like to explain a little bit then two bad factors which can influence the possibility of bile duct injury. Is first acute inflammation, and another is chronic inflammation. There is a lot of discussion between many doctors and between many clinics what is better, and mostly it's like a guideline. Then we are trying to operate not in acute phase, but we are trying to treat conservatively acute cholecystitis, and then to perform elective surgery after 6 or 8 weeks. Next one is human factors, and there is a lot to talk and to know and to follow. Of course, very important is general condition of the surgical team, of the surgeon who is doing this laparoscopic operation. He has to be healthy and not tired. Experience. Here in literature, I found a learning curve, which is also recommended number of operation, and in different literature is from 30 to 100 operation laparoscopic cholecystectomies. So that means then if the surgeon is experienced, so the risk of injury is less. Then next step is prolonged laparoscopy and visual delusion. If surgeon is doing operation, so he is going to operation and he knows what he have to find and what he have to do in this area. But sometimes due to many aspects, let's say due to anatomical difficulties or bleeding, this is not easy to do. And the time of operation start to be longer and longer. And what means visual delusion? We'll show you next step. So you looking at some things, at tissues, and you are trying to find what you imagine to find. Yes, we are searching for ductus cysticus and arteria cystica. But there will be, there can be some other structures which can just lead you to visual delusion. So I found in literature then recommended time to convert operation is 30 minutes. But again, this is very discussable question. Of course, it depends of experience of the surgeon and on individual view also. I know in my previous clinic where I was working, we had like this, like a rule: if I cannot find an anatomy and I'm not sure, so it was a rule, then we are converting after 30 minutes to open. But in other cases and other clinics, it can be different. And there is also one interesting fact. Then literature says, and then 97% of bile duct injuries is due to visual delusion, and only 3% due to surgeon's experience. Next step, of course, is very important: adequate operation teamwork. Then this operation should be should do two surgeons, not only one and nurse, but two surgeons. It's very important, and if some problems, unexpected problems occur during operation, then other surgeon, your colleague, can give you advice. And one smart head is good, but two smart heads is much, much better. And last, of course, is technical things, technical supply. Now in these times, I believe in all hospitals who are doing this operation, they have quite good technical, but it's also important then assistant is able to show the picture and showing it's right, and the focus and the visual understanding of the picture for the main surgeon is clear. And other operation techniques, good operation technique is also very important, to do it gentle. Okay, so let's think then, during this laparoscopy, the injury is done. The injury could be done actually to any bile duct, and for bile duct injuries, there is a numerous of different classification, but I am using this Strasberg bile duct injury classification, and there is again a little bit of anatomy. So I would say then most usual things is type A injury, and also type E, different variation. If it's happened, so we need to do something, we need to treat it. The treatment strategy depends on many factors. First, do we find this during operation or after operation? Most of the in researches, most of the bile duct injuries are found during operation, but there is some number, of course, which is found after. Then, of course, it's very important imaging. Intraoperative whole angiography, ERCP, CT, MRI, depends on when we found this, or when we are suspicious about bile duct injury. Then when we get an image, or when we see this, so we need to classify. The classification is very important to understand what to do. And then in the last, we are making a decision what to do. So here is a summary of treatment strategies. And for type E, what is type E? What is type A? Type A is leaking from the liver bed. Usually it's some small, like Lachka duct, some small bile duct. And in this type, recommend ERCP, stenting of common bile duct, and usually leak stopped. Also subhepatic drain to drain the leakage. Type B. Type B is when we have anatomical variation with a right additional hepatic duct or aberrant hepatic duct. So B is when this additional duct is transected and flipped. So there is no, the problem is then there is no gall outflow from the right liver segment. So in this case, recommended US guided segmental liver drainage and conservative treatment, or segmental liver resection. Type C. Type C is a little bit different. So you can see then this aberrant additional liver bile duct is leaking. So it is common that the bile leak is occluded spontaneously with no other intervention, maintaining a controlled bile leak through subhepatic external drain. If it does not happen, then the treatment is the same like in B, this previous case. Type D, this is a marginal or partial injury of the common duct. And if it is really small damage, so recommended to place a T-drain to fix it, and or to suture it, but then I would say it should be really small damage, and to place endoscopical stent. And type E. Type E is only possible treatment is choledochoieumal anastomosis type rule. This is a T-tube which is placed in partial common bile duct damage into the common bile duct, and then we can control the situation and bile drainage external way. And this is this complicated reconstructive surgery. Here is the transected common bile duct, and yellow loop is sutured together, and one additional anastomosis. Okay, this is from theory, and now I would present you two cases. One is from this hospital, and one is from my previous hospital. This case was rather classical case for elective laparoscopic cholecystectomy. So a young female which went to elective surgery. This picture is just regular ultrasound picture where is seeing gallstones, and there is no information about some anatomical anomaly. Surgeon who was doing this operation is very experienced, and his experience is more than 85 laparoscopic cholecystectomy operations. So if we are this, I put this thing to just remind about this learning curve. If we are analyzing the case of injury from different aspects, then duration of laparoscopy before the injury was less, so it was not a prolonged operation, and it was E1 type injury by Strasbeck, so that means then the common bile duct were transected lower from the hilum. The injury was found during operation and treatment. It was converted to open. Intraoperative cholangiography were done, drainage, and transportation to hepatobiliary surgery team. There, they made a reconstruction, RU and Y holidecholeiunostomy. Then I found an information about a 9-month follow-up. Then there is no episodes of cholangitis, no gallstone attacks, no stricture of the common bile duct, and normal blood tests, which is a very good result. Here we can see the intraoperative cholangiography, where the instrument is put. There is a site actually of transection, and this tiny line, this tiny shadow is a catheter to put in contrast. So this is the first, and now the second. Second is from hospital in Latvia. This is also I was working also in a regional hospital. Actually, I was analyzing this topic for bile duct injuries. Like I did a retrospective study for 3,000 laparoscopies, and in our hospital we had 8 bile duct injuries to 3,000 laparoscopies. That means that in percentage it's 0.26. It's also it's good number. But of course, all of these cases were very dramatic and very painful for the surgeons, and of course painful for the patient. And this operation, this case, I remember, I was not in the first operation when the damage were done, but I was in reconstructive surgery assisting. So that was also a case of elective surgery for 56-year-old female. Also, no anatomical anomaly in prior US study. Ultrasound were done, and there was just everything okay. But when, of course, operation were started, then the problem was then the ductus cysticus were very short and very connected, very close connected to common bile duct. I think if we can go back, then it is the picture C or E. C or E. Then the surgeon's experience were good. He did more than 100 laparoscopies. Duration of laparoscopy before the injury were more than 30 minutes. It was really, he was trying to understand the anatomy and to continue this operation like laparoscopy. Of course, he was experienced and he was believing then he can do that. But it was quite prolonged. Then what kind of injury were done? It was E1 type injury by Strasbourg, this total transection of common bile duct. Actually the same like in previous case I showed you. And also found intraoperatively. Treatment, conversion to open. Intraoperative cholangiography were done, were clear when then yeah, it's no doubt this common bile duct is transected, and they did an immediate reconstruction, cholecystectomy. It was possible on that time, on that place, on that clinic, and by that surgeon. Follow-up was quite prolonged and I would say very difficult. Then this woman had severe cholangitis 6 months after the first reconstruction. 3 millimeters primary stricture were found. It was stented. Then she lived 2 years with no complaints. And then she were admitted to hospital in very acute condition with recurrent cholangitis, choledocholithiasis, jaundice, and on that place, on that time we did an open laparotomy and open stent removal. And she was spending quite long time in hospital, receiving also other additional conservative treatment. I was able to follow her up 1 year after that operation, so she was quite in good condition and were no recurrent cholangitis. But I believe that for that lady, the story will continue. Since I left Latvia, I am not able to follow her anymore. So my conclusions. Bile duct injury during laparoscopic cholecystectomy is quite rare complication, but it's serious. When it occurs, it's very dramatic. Surgeon can try to avoid it or minimize it by using gentle approach, dealing with hepatobiliary surgery, convert to open and ask for specialized help facing any unexpected intraoperative difficulties. And this is very, very important. Not to believe only to yourself, but it's good to ask for help. In case of bile duct injury, surgeon, radiologist, gastroenterologist, teamwork is super important. Yes, it's again, we need to ask for help. To perform cholecystectomy, or especially narrow bile duct, the surgeon have to be skilled in hepatobiliary surgery. That's why it's normal then if the surgeon is not skilled in this procedure, it's normal, absolutely normal, to send this patient to hospital, to university hospital, where the surgeons are more experienced in this kind of operations. Main long-term complication after bile duct injury is stricture due to intermittent cholangitis, and ERCP and stenting is necessary in case of strictures. Thank you very much for attention. Yes.
Yeah, thank you, Alise. You told me this was your first lecture in English yesterday,
Yes.
and your next one will be in Icelandic. This is very good and very important topic to discuss. And we have this for the patient, and everybody concerned, very traumatic experience with this case here. But I can tell you that this is we have done. When this happened, around 1,500 cases. This was the first one here, one in 1,500. And I was going to ask you, these 8 in 3,000, that was when you needed to do this blue and white for transaction or so much injury that you had to do like this?
No, it was not for all cholecystectomy. One case was with T drainage. It was marginal injury, but 7 were total transaction. Yeah.
Yes, thank you very much. Interesting. There are some areas there that people are discussing, and they have different guidelines. One is hot or cold operations, and you mentioned that. Another one is intraoperative cholangiography. When to do it. This is a rare occasion that you have such severe injury, but some surgeons do it more often than others.
Yes.
What's the guidelines? What's the golden standard? Is there one?
Well, the golden standard, I don't know, is it a golden standard, but it's possible if you are not sure. If you are not sure and you are suspected of some anatomic anomaly, to ask for intraoperative cholangiography. Yes, this is first. So to do it before you did an injury. Yes, and there are other cases after injury to see it. Yes.
Thank you, Alice. English was good. Than mine as well. Yeah, this happens, and thankfully, the RCP can help. Because surgeons help us a lot, so it's nice to be able to help. I've been doing papillotomies and stents, though the literature suggests that you don't need the papillotomy. But I began that way, and it's worked, so I continue to do it. Do you know anything about that? Were they just putting stents, or were they doing the papillotomy also in your hospital?
Yes, they are doing also papillotomy, yes. Yes.
Again, this case where you were describing, was the same stent there for such a long time before it occluded?
Before it occluded, okay.
Because I think we are right in that we often do changing of stents in these cases.
Yes.
Or a review or something like that.
Yes. Of course, the history I have in my documents say that she had a first stent, and I believe that this stent were not removed, so it was too long time for this stenting. Maybe this was the reason for restenosis.
We've discussed that. The usual recommended plastic stent is 3 months. But then again, we've had people who have them for a year and have had no problem with that. It depends on the type of bile people and the reaction of the plastic. But leaving stents longer, you're going to ask for complications, cholangitis. The other thing too, as far as strictures go, one stent usually isn't enough to open up that stricture. So sometimes we're putting 2 and 3 stents. I think the world's record from Costa Magna, was a big ERCP man from Italy, was 26 stents to open a stricture.
Yes.
He's Italian, he drives a Lamborghini.
Yes.
It's just that this reminds me of course, we have had problems, but not as severe as this one. This reminds me of my problem that I can never forget. I've done between 500 and 600 cases, and this was maybe between the 100 cases or something like that, or something around that, I should say. And then I accidentally put a stent on the choledochal. Clips. I didn't resect it. So we saw it after the operation because he got pain and he got yellow. So Nick did a ERCP and we saw this. And we did open surgery and we took away the clips and Nick put in a stent. And this guy has to come very often and change stents and has 2 or 3 stents. And it went well, but it was work. He got some cholangitis, but in the end, there were some years we didn't hear something, and I really don't know. He must have died by now. He was so old. I don't know. But anyway, this was my thing that I think it helped him to have him currently here and investigate and change stents and have maybe one.
Yes, of course. This follow-up is very important.
Our record, one talks about that. There's 23 ERCPs for a scripture, and he's 3 years afterwards from the last sending. I called him a couple months ago.
So he's alive?
He's alive and doing well. And it's interesting because his name was, he had a big stone too, and his name was Alise.
Yeah, okay. Okay.
And his hobby is polishing stones.
That's right. Yeah, that's another guy.
Yeah, I just want to mention I have a similar experience than Ali. It was maybe 15 years ago here, and I'm sure about 200 laparoscopic cholecystectomies. It was a young girl. She was in her 30s, I think, and it was a very easy operation done by an experienced surgeon.
Yes.
And there was a narrow structure that went up to the gallbladder, and so nothing unusual with that. I put 2 clips on it, but of second thoughts, it was, well, didn't see the anatomy clearly enough. So we decided to open it up, and then we saw that this was the common bile duct actually that went up to the gallbladder and went down into the liver. So I had almost transected this bile duct there. We took the clips away, and everything went well until she got stricture because of the inflammation. So me and Nick, we had to put the stent a few times and dilate this a few times, and that everything was okay. But it was close. So since then, I've always had great respect for these operations, but with every year I get more and more respect, and then more and more afraid for these operations. Get older. So this thinking, this topic, this thing you mentioned, the experience of the surgeon, that this doesn't always solve the problem.
No, it's not always.
The danger is always there.
Yes.
I was lucky at that time.
Yes.
Einhver fyrirspurnir? Takk fyrir kærlega.
Thank you, Alice.
Yes, thank you.
I don't know if that-
Went well.
It's really good, really good.